Oh, okay, Laurie, we can continue now in English. Thank you for your, I don't know, valuable participation with the Association of Neurorehabilitation for Latin America, and all yours, the time and
Okay. Thank you so much, Pablo. And good evening to everyone. Thank you for the introduction as well, Pablo. Um, as Pablo mentioned, this is my background, and I guess what I'd like to highlight is that I worked as a physical therapist for about 15 years before I went back to get my PhD in anatomy and neurobiology. And then I also did my master's in clinical research, which kind of helped a lot with the work I do now in clinical research. Okay, I have no disclosures. Okay, so I'm just going to jump into this. I'm going to be talking today about traumatic brain injury and rehabilitation and talk a bit about new directions that the field is going. Um, Traumatic brain injury is a common problem here and also in Latin America. These statistics are from the United States, showing that about 190 TBI-related deaths happen every day. What I'm showing here is that, well, first of all, traumatic brain injury is more common than men compared to women at about a 2-to-1 ratio. But what's really interesting too to me is that there's different age groups are more susceptible to brain injury. You can see from this graph that there's two time periods that people are most susceptible to brain injury. One is in this adolescent period, and another is as people get older with falls. And you can see from the graph that the mechanism in the younger adolescents is often motor vehicle accidents. In the older people, it's falls. When we talk about TBI, most of the cases are considered mild traumatic brain injury. And the term can be interchanged with concussion. So we're talking tonight about concussion slash mild traumatic brain injury. This this shows you that about 80% of the brain injuries are considered mild traumatic brain injury. This is a crazy complicated slide, but I'm trying to make the point here that we have a lot of guidelines for concussion or mild traumatic brain injury. And you can see that they've come from a lot of different areas. So they've come from the American Academy of Neurology, American Academy of Physical Medicine and Rehabilitation, sports medicine, athletic trainers, and we have an international consensus group that every couple of years gives us more guidelines on how to treat this population. Physical therapists also have their own guidelines for treating and organized around sports. So all the guidelines that come out are around sports, young people. And as I showed you in the previous slide, the problem really is like older people as well. So it isn't just athletes and soldiers getting concussions, it's a
Personas
regular
mayores
population.
y no solo atletas y soldados.
So what do we do with these people who are just regular civilians? Because at least where we practice, I'm not sure where other people practice, but where we practice, we don't see athletes and service members very often. We actually mostly just see regular civilians for rehabilitation. And when we looked at, we published this paper just recently, we looked at the trends in regular civilians after they get a concussion. And what we found, you can see from the graph here, is that the gray is their time from their injury to their first physician visit. And you can see that that happens pretty quickly. So it's on average like 5 to 10 days. And you can see they're all grouped together. However, their first physical therapy visit is, first of all, it's really spread out. So there's no consistent guideline on when to initiate physical therapy. It's spread out, but it's also pretty late. When you look at the average time point, it's 60 days. So from someone to have a concussion to get seen in physical therapy takes about 2 months in the United States. And that's been published with our group and our hospital, but also in another publication that had the same time frame. So that's a pretty long time another guideline from the Physical Therapy Association here in the United States. They published this a few years ago and basically broke down how we're meant guidelines for both evaluating and treating someone after concussion. So they put these into buckets. So they have cervical impairments, vestibulo-ocular, autonomic dysfunction, and then motor function. And what the colors show is the level of evidence. And so what you can see from the orange is sort of like the best evidence we have. Sorry, let me just move this out of the way. Yeah, and so what you can see is that, sorry, the green is the best evidence we have. And most of this figure shows like pretty weak evidence. So kind of the take home here is that these are the guidelines, but the evidence is not very strong at this point in the literature. So talking about, when you think about those buckets that we're meant to look at, vestibulo-ocular is one of them. And that had the biggest evidence with it, primarily related to positional vertigo. But when we look at our people that come into our clinic and into our studies, so this is data from a group of people that had chronic concussion. So these people were past their injury by three months. But they're not far from the people we see in the clinic. And they're people that come into us and they still have balance deficits. And they complain of creating the imbalance. And what we found, though, is that when we tested them in the laboratory, we looked at oculomotor assessments and we looked at vestibular assessments. And I have them listed, and these are all laboratory measures we do in a vestibular lab. And I'm not going to go through the test, but they're objective measures of eye function and vestibular function. And when we compared them to healthy controls, as you can see over here in the p-value column, there was no difference. So these people, even though they have complaints of dizziness, imbalance, their scores look pretty normal in all of these assessments. So you can see there, they're all pretty high values. And so I'm talking about the chronic people, because possibly what happened is that most of the data, like I said, has been based around athletes, and they get tested right after the injury. So they're sort of like right in that immediate or acute phase. And there may well be visual, oculomotor, vestibular problems at that time, but by the time we see them in therapy, there doesn't seem to be. So we're kind of looking at subacute, acute. These are our populations. And I put this slide to make the point that when we did have a group of about 140 people with subacute, and I'm defining that as between
Etapa subaguda, y voy a definir esto como una etapa entre 3 semanas a 3 meses. Lo que ustedes pueden ver acá es que los mismos test vestibulares
particularly oculomotor that are abnormal. So we look at smooth pursuits, VOR, vertical and antisaccades. These measures had some abnormalities in like between 30 and 60% of the people in the subacute. So this picture is sort of different depending on, and we'd probably see even more if we looked at the really more acute phase. So the question then becomes, why do these people continue to have problems with balance? If their visual vestibular system is normal, where is the problem coming in? And so when we started this work, we thought it's probably because it's more central in its nature. So more in the central sensory motor integration. And so we thought probably that's where the problem is breaking down for people's balance control. Just to kind of explain this slide, looking at postural control as a feedback loop, we have sensory information coming in, it gets integrated in the brain, and then we have like a motor output to maintain balance. And to talk a little bit about sensory integration, we also can refer to it as sensory weighting. So when you think about how the information you use for sensory weighting 100% of it is going to come from 3 sources. So it's going to come from proprioceptive information, vestibular information, and visual information. So for example, this person who's playing baseball, it's a well-lit environment, firm surface. This is the breakdown of what this person get into a situation where either it's dark and you can't see, like the picture here of the army, then people immediately, healthy brain will downregulate vision information and upregulate both vestibular and proprioceptive. However, if say you're on a boat or you're walking on an unstable surface, then right away a healthy brain will downregulate proprioception and upregulate vision and vestibular. And that's kind of clear from this picture of the person hiking. He's having to really look where his feet are because the proprioceptive information is not reliable. So that's what we mean by sensory weighting. So we thought with concussion, maybe the problem is they're not weighting their vestibular information correctly or visual. And so maybe that's why they're having continued balance deficits. One way that we measure this in the clinic, and people may or may not be familiar with this test, it's called the sensory organization test. And the way that this test works is that there's 6 conditions and it systematically manipulates them in order to figure out which condition you're breaking down in for your balance control. So for example, condition 1, you have all your senses. You're just standing, firm surface, looking straight ahead. Then you close your eyes, and then you're going down to just 2 senses. And then in the 3rd condition, the visual surround moves, so it's giving you inaccurate information. Conditions 4, 5, and 6 are exactly the same, but now the surface is moving with you. So if you're standing on the surface and you go forward, it goes with you. So it's almost like standing on foam or being on a boat. And so it systematically manipulates this to try to tease out where what the problem is with your sensory information. Okay, I'm going to just skip that for a second. Okay, so now what we've found in our studies, and others have found this as well, is that we saw deficits in the sensory organization test. And so we thought, okay, this is the problem. They have sensory integration problems. But then when we looked at the breakdown, because it gives you these ratio scores, for example, is the breakdown in the sensory somatosensory information? Is it in the visual or vestibular? But we couldn't tell. So every category seemed impaired, which doesn't really help direct your rehabilitation. So it was helpful in one way, but not helpful to direct rehabilitation. And so this is where I want to talk about this test that we now use in our lab as a way to gather more information about where the problem is breaking down. What I've just talked about so far, this is a model that was developed by Bob Paterka, who's here at our institution. He's an engineer, and he developed this about 25 years ago. And it's the nice thing about this, oops, sorry. Okay. Okay. The nice thing about this test is it's done on the same platform that the Neurocom is on. But the information you get is not just about sensory information. So what you get in this first part is the sensory weighting, like I talked about. But in addition to that, you get a time delay in the motor activation and body sway values. So on this one, the stimulus moves and we run them through the test, but then we take the data from the force plate and run it through a mathematical model to get these different variables. So this allows us to see where the problem really is breaking down in terms of sensory, motor activation, and time delays. So what we found, so we use this in our chronic MTBI group. And what we found, interestingly, was that the sensory integration, that weighting I talked about, was totally normal. time delay and motor activation and body sway metrics. So these are more, if you think about, it's less the sensory problem, but it's more this motor activation problem, which might explain why they're still having deficits and they're still getting re-injured in their sport or when they go back to duty. So after this, we wanted to know this just to show you what this really looks like. If I'm talking about these parameters of time delay and motor activation, what it ends up looking like in the person who has a deficit there, they're standing on the force plate, and it's a little bit like those cartoons down below. It's kind of like a sloppy control of their balance. When the healthy controls stand on the platform, and it's only moving 2 degrees, so it's a very small movement. But the healthy controls, you can see that their body sway angle can stay within those 2 degrees in either direction. Whereas the MTBI patients, they're getting a 2-degree stimulus, but they go much further in both directions. So at the end of the day, they're more sensitive to a perturbation and with this kind of sloppy balance control mechanism. And one thing that might be interesting, because I wanted to highlight these 2 studies that were really big studies on professional athletes, basketball players. The league did this study. "90 days after the concussion was 4.5 times greater in this concussed group." And this is after they've been recovered, they're cleared to play. So it seems, and the second study was the NCAA, and they found a similar thing. They found 2.5 times higher rate of a lower extremity injury when they returned to play. And these are people, like I said, they're recovered, they're cleared to play, but clearly something is different and something's off, which could partially be explained by this prolonged motor activation and latency deficit in their balance control. So in thinking about sort of like the trajectory of recovery, we're focusing on these 2 areas, subacute and chronic. And the mechanisms of imbalance might be very different in the early stages, and it may well be that sensory information. But when we look later on, we were interested in looking at how people are like sort of recovering over time. So this is the results that we found using that same test. So this is looking at vestibular weighting. So how much are you using vestibular information when you have no vision and your proprioceptive information is incorrect? So you're standing on the surface moving. What we see here is healthy controls, subacute, and chronic people. So the difference between a healthy control and someone in the subacute phase was significantly different. So these people in the subacute phase went back up to normal, which is kind of what we saw in our chronic. This looked totally normal by the time they were, 3-4 months outside of their injury. But there was this subacute time period where it wasn't normal. When we look at visual weighting, now this is when you have inaccurate visual information. So it's a little bit like if you're driving and you're at a stop sign, and the car behind you, the car next to you starts going, and you feel like you're moving, and you have to kind of check yourself, like, oh, you slam the brakes on, but you're not moving. So the ability to realize you're not moving, you're inhibiting information that's incorrect from your visual system. That's what this is like. So the surround is moving, but it's inaccurate. So you want your visual information to be low. But what we see here is that it's a little bit higher in the subacute, but by the time they get to the chronic, they're relying too much on their visual information. So they're relying on visual information when it's not helpful. And this could help explain some of those musculoskeletal injuries, especially when you think about athletes running and all the visual motion that they are undergoing when they're playing their game. now looking at the time delay, we see that it's longer. So this time delay, you can think of it as a delay between the information coming in and the motor output. So the time delay in the subacute phase is long. Recovery. And we saw that we actually saw this in all the conditions we looked at, so all the sensory conditions. So it's impaired in that subacute stage and it stays that way. And then, so interestingly, the motor activation, which is like, if you think about the time delay is the time till you have an activation, then there is an activation. So what kind of like torque are you producing for the imbalance, the perturbation? And like I said before, they were sloppy, like that cartoon of the balloons going back and forth. So they tend to have like a lower motor activation, so they have like a sloppy balance control. But that seemed to develop over time. So like in the subacute phase, they still look pretty normal. And this kind of lower motor activation develops as a compensation for the long time delay. So the time delay is long, so they get sloppier to avoid falling, basically. And you can see that by the time they're in the chronic phase in these conditions, they're considered outside of their abnormal at that stage. So this kind of time delay seems to be a main theme with people after concussion. And actually, we see this across different measures. So we test them in a whole bunch of areas. So this is what I've just been showing you. Oops. This is what I've just been showing you, the standing balance. You can see the healthy controls compared to the MTBI. Very different. That's in standing. We also have a test. If you guys are physical therapists, you might know about the mini bus test. And there's an item in that test, which is called the push and release. So you can see the picture. The patient leans forward. The examiner lets go and the person takes a step. What we do to measure this is instrument it using an IMU, like wearable sensor. So we can calculate how long it takes the person to become stable. And you can see that the MTBI looks very different than the healthy controls. It takes them a lot longer to get stable once they have that imbalance. And then cognitive assessment is another big area for concussion. And when people look at computerized tests for simple reaction times, they take longer for those kind of tasks as well. So there's kind of this time delay across many different measures. Because a lot of times, at least with the athletes, they're cleared to play based on a cognitive test. It's called the impact. So if they score okay in the impact, it's kind of assumed that their reaction times are okay. But what we're seeing is this this cognitive assessment with the time delay is like essentially no correlation, and same with the cognitive with the time to stability. So you can't just test someone on one and assume they're normal on the other. Okay. So what does this mean for rehabilitation? So I'm saying we see very few deficits in this vestibulo-ocular. And it kind of makes you wonder, like, with what we do in physical therapy, are we treating these motor deficits? Because from what we've seen here in most clinics, most therapy for concussion and balance control is very sensory oriented. So they have people standing on foam, closing their eyes, and it's very sensory oriented. So we were curious, like, now that we have these measures of this motor activation, how is therapy that we give traditionally helping people? So we did a study where this is like standard of care, those 4 buckets. We did autonomic, cervical, static balance, which is more like vestibulo-ocular, gaze control and stuff, and dynamic balance. And we just did the regular kind of rehabilitation. In this So we just did the most basic, like common practice, best practice that we know for rehabilitation. And we had people start at different times after their injury. So this was kind of the setup. So people got randomized into early rehabilitation or standard of care, which like I said, was we made them wait. And we know standard of care is, like I said earlier, 2 months. So, and then we post-tested them. And then the late group then got their therapy, and then we post-tested them again. So we randomized people, and we had 100 and close to 200 people in the study. And here's what we found about timing. Okay, the blue group is the early group, and the red group is the delayed group. And this is an assessment tool that's just symptom-based. So you ask them about all their symptoms. It's called the SCAT. And so looking at the early group first, their symptoms got better during therapy, and then they retained it even without therapy. And whereas the late group got better, but at a slower rate, well, they just waited, they were on the wait list. Then they got therapy, and then they amazingly got to the same point as the early group. So they got to the same point, but it just took, 2 months longer. So that was, and we weren't surprised about this because there's a lot of populations that's been studied, and early intervention for rehabilitation is almost always better. So we weren't really surprised. Pre to post early group got better, significantly better. The delayed group got better on their own, and they continued to get better with therapy, reached the same point, just take longer to get there. Same story with the dizziness handicap inventory, the DHI. Early group got better faster. So this wasn't surprising, but it was good to have sort of like evidence to show that early rehab is better. But where it got very interesting was in these motor activation measures that I've been talking about. So when we look at the time delay, and that's the one that I showed you that was delayed across all conditions, we look at the early group got better, but normal is right down around 150. So they're still not totally better. The delayed group didn't get better at all on their own, and they didn't get better with therapy either. So it seemed like there might be a window where intervention is really important to get at this mechanism of imbalance. So that was time delay. And then with motor activation, again, they start with low activation. We want it to go higher. So the early group got a little bit better, but actually not that much better. It wasn't significant, and the effect size was only 0.1. So they were going in the right direction, but they really didn't get better. Normal is up here around 150. But the delay group, while they waited for therapy, got worse in these measures, and then they stayed the same during therapy. So two kind of messages from this was that there might be a window where intervention is really important. Improving these measures all that much. Even the time delay, the effect size is only 0.3, which is like really minimal. So, and by the end of therapy, their symptoms might be really improved, but they're still having these deficits, and they're not back to normal. So the question then becomes like, are our current recommendations for physical therapy addressing these motor activation deficits? And it doesn't seem like they are from our studies. So the question is, how do we work on motor activation? We did a small study using auditory biofeedback for balance control. So we had them wear these earphones, and we told them when they're perfectly still, this is quiet. They don't hear anything. When they're swaying back and forth, it'll go in the right or left ear. When they're swaying front back, it's a pitch, so up, down. So the instruction is keep the noise as quiet as you can when you're standing with your eyes closed, or whatever task you're having them do. So they put the headphones on, and it immediately works. Their sway goes down. So this seems like a good possible way to work on that the time delay, because it can happen quickly, intuitively, just with that feedback. So we did a study with 15 people using this device and 15 people just doing regular vestibular therapy. And what we found, well, this was the therapy we did. And then we'd layer on things like tossing the ball, turning the heads. But the group that had the biofeedback, throughout all these tasks, their task was to keep it silent. So they were getting feedback on their postural sway. And what we found for the results on this one, and we published this a couple of years back, the SOT, which was that clinical scale I talked about in the beginning, that it's on the same platform, but it really only gives you information on the sensory stuff, and you can't break it down. Both groups, and this was really good because these were chronic people, both groups improved a lot. Like anything in this blue zone is like a high effect size. So both groups really got a lot better with the intervention, which was good. But when we looked at these motor activation measures from the CSMI test, it was only the group, the clear ones, it was only the group that got the biofeedback that got better. So we thought this might be a good tool to use in the clinic to give feedback, to start working on that motor activation mechanism. And actually, we just got funded to do this study, which we're really excited about. From the Department of Defense funded us. We're going to design an exercise program that just works on that motor activation. And then we're going to test it, do a randomized clinical trial, and test it against the standard of care, which is like sensory. And so this was some of the, like down below here is our standard of care that we did in all of our other studies. So cervical, autonomic, vestibulo-ocular, and motor function, and just some of the things we do in therapy. Some of the newer things, we're trying to design this program over the next 6 months before we start. Doing that, using the biofeedback for static standing, working on stepping, maybe perturbation training. We're trying to come up with ideas on how could we work on like speed, quickness, stability, and then test it against the sensory program. One other thing I'd like to mention, this is kind of the last point in terms of like new directions and trends, is that there's a move going on to try to subtype people with concussion. And these are the subtypes that have been published. So there's oculomotor, vestibular, headache, migraine, anxiety, mood, and cognitive. And the idea behind this is a person. So they might need physical therapy if they're oculovestibular. They might need neuropsychology if they're cognitive or mood. So there's this idea that, and people are working on developing scales so that the clinician could ask them about their symptoms and then put them to the right person. But what we found, interestingly, with these measures, like this one is the CSMI time delay. We found that regardless of what subtype you were, except for headache, but if you were vestibulo-ocular, cognitive, and mood, you were still very different than the healthy controls in your time delay and quiet standing. And this is really important because if a person gets diagnosed or classified as a cognitive subtype, they're not going to get sent to physical therapy, but they still have these motor deficits, it actually makes sense when you think about the mechanism of a concussion. It's a white matter, it's a diffuse white matter disease. And so when you have a concussion, it's not just like one part of your brain. Even if you hit your head in one area, it's still the white matter that's impacted. So it would be some of these people that have cognitive might never make it to physical therapy. Yet they might be the people that are getting re-injured on the field because they actually do have balance deficits that haven't been looked at. And it's the same, we saw the same story for reactive stepping from the minibus test. really different than healthy controls. So it's kind of the same story that we saw with the time delay measures. So in conclusion, one of the things I was trying to highlight in this talk is that rehabilitation, MTBI kind of evolves over time, and rehabilitation needs to factor that in. So when you see someone acutely, they may well have a lot of oculomotor and vestibular deficits. But when you think about their phase of recovery, they look really different, whether they're in the subacute or chronic phase. This longer time delay may actually represent like the main deficit in the people. By the time we see them in therapy, it might be the main deficit that we should be working on for physical therapy. And then also the subtype model, it's a good idea, but it might oversimplify balance control in terms of referrals. And really all subtypes might be impaired in balance control and might need to go to physical therapy for that. And then lastly, considerations on how do we add this kind of motor activation components to rehabilitation? Like, what are some other things we can do? Like, we came up with that audio biofeedback. We're working on perturbation training. A lot of other patient populations do work on perturbation training, like Parkinson's disease, for example, because they have more obvious step initiation problems. And so they work on perturbation training for a different reason, like they're trying to practice quick recovery steps. But maybe perturbation training for this population is trying to develop in this next grant that we got. So hopefully, hopefully we're going to come up with an exercise program, do the assessment, and see if that makes a difference in our outcome measures. And then this is our balance disorders lab here that Pablo is a part of. And you can see from our list of names, we have a very kind of diverse group of backgrounds. So we have research, physical therapists, exercise trainers, engineers, lots of different backgrounds to try to come together and address the problem of rehabilitation and balance control in various disease states. So I'm open to questions. Hopefully you guys got the translations from that. And I'm happy to answer any questions that you guys have.
All right. Thanks so much, Laurie, for the talk. And thanks, Carolina, for the translation. And yeah, we have a couple of questions in the chat. I will be reading a question for you. The first one is from, let me come back, Pablo Lefort. He's asking, what are the, I don't know, clinical criteria to define mild TBI?
Oh yeah, let's see. I kind of went over that. I'll go back to this one slide here. Sorry, it's way back here. Here we go. So there's a table down here that we go off the Department of Defense and the VA published this criteria. So Glasgow Coma Scale is between 13 and 15. Imaging is usually normal in this group. So a lot of people don't even have imaging, but if they do, it's normal. Loss of consciousness can be nothing up to 30 minutes. And same for alteration of consciousness can be up to a day. If it's more than that, it goes into moderate. And post-traumatic amnesia would just be from zero to 1 day prior to the injury. That's how we define it.
All right. Thank you. And the next question is the association between cognition and motor reaction time, but I don't know. The same people is telling us that you show some slides demonstrating that the correlation is not.
Yeah, the correlation was not
weak. Yeah, it was weak.
Was like non-existent. It didn't.
Yeah.
Yeah, which I was a little surprised at. This was the correlation.
And why do you think the cognitive, I don't know, response is not associated with the motor response in this case?
I know. I think just because the injury is so diffuse, I think. I don't know. It's, yeah, it would be nice. Tracks of the brain are different, depending on the task.
Yeah, yeah. The next question is about a kind of adaptation of the rehabilitation for people with amputation or other kind of traumatic injuries in the body. I don't know if probably in the studies are not included, but I don't know if you have experience with this kind of adaptation for other lesions.
Like adaptations for
The
getting.
modification of the rehabilitation in relationship with other traumatic problems in the body, or I don't know, legs or trunk, or yeah.
I don't know if I totally understand the question, but
Yeah, he's asking for amputation, basically after, I don't know, vehicle accident. Usually it's not
yeah.
just the brain, it's also some
Yeah,
lesion.
I mean, I think the difference is like some things like amputation or stroke or Parkinson's, like it's so obvious there's a motor problem that the therapy you wouldn't start doing vestibular rehab on like someone with an amputation. So I feel like in those patient populations, people are doing more like perturbations and adapting. But the thing with concussion is there aren't like obvious motor problems. They walk pretty normally, you know. Um,
Hmm.
and it's all they just feel imbalanced. So that's why it was kind of always like, oh, they must just have vestibulo-ocular that doesn't resolve. But in other patient populations, I think people are already doing motor activation and latency training, like
Mhm.
with steppings and perturbations and things.
And one extra question, did you see some kind of Usher syndrome in TBI, or is more associated
No,
with a stroke?
we haven't seen that. No.
Okay.
Because I mean they're so mild in a way, like mild, but it's not mild if it's you because they can't get back to their life. Like, but it's not like seeing someone with a stroke or that has like Pusher syndrome. It's much more like subtle deficits, which is harder clinically to measure, because it's not as like overt. Yeah.
Yeah, I have two more questions. If
Okay.
I understood well, the problem with mild TBI is, for one hand, is in the sensorial system and the motor reaction time. This is the two main impairments, or is mainly the
It,
the motor reaction time?
yeah, it's mainly the motor reaction time.
Okay.
Yeah. Especially when you get beyond subacute, like later as you're out from your recovery. I
Okay.
think I was trying to make the point that it changes over time because a lot of the studies are done on athletes and like, 4 days after injury, and they do have like ocular problems but by the time they get to subacute and chronic, which is when we see them in therapy, they don't usually have those anymore because they change and then they develop more of the motor latency problems.
Mhm. And my second question is about the, I don't know, categories of rehabilitation in the last study that you showed in the
Mhm.
last slide. Why did you define, if I remember well, I don't know, was turning, reactive balance? I don't remember well the all the.
Oh,
And how is, I don't know, matching with the literature about the TBI rehabilitation? Because you show a kind of uh, big categories of rehabilitation, the cervical one, the
oh
oculomotor,
yeah.
and you are training different categories of, and why
This one?
did you choose, I don't know, these categories basically?
Yeah, I mean the categories down below are published practice guidelines, cervical
Oh,
autonomic. Like those are just out there. That's standard of care.
oh,
Um, this one activation. And so we were trying to structure it in a way that was like systematic. And actually part of this project, we have 9 months to develop the program for motor activation. And so we have like, we have like focus groups, and we're trying to get ideas from people on what we should be working on. So this was like what I put in the grant, because it was us just saying like, we might do something like this, but we have to develop it better. But this was our first kind of pass at it. Yeah. It might end up looking different after we go through our development of it. Yeah.
Awesome. And we don't have more questions. I have, I don't know, one more if anyone have one more.
Okay.
Sorry about this, but I understood that the main emphasis during the rehabilitation should be the speed, or basically the reaction time, the decrement or decrease the reaction time.
Right.
What is your suggestion? I don't know, using these categories of static or dynamic balance or turning. Basically, we should emphasize, I don't know, something like as fast as you can, or which kind
Like,
of exercise, I don't know, do you suggest for the clinical practice?
I know. I mean, that's why we're doing the study, because we don't really know. And you guys might have more ideas than us. I mean, we're like really early stages trying to figure out. But I think it's like like they do drills, like cutting, and they do all these like speed accuracy type things, which we don't really do in physical therapy as much. So maybe some things like that might be helpful. And that's what we're trying to figure out with this next project.
All right. And now we
Yeah.
have more questions. If you have time,
Okay.
I don't know if it is okay for you, Laurie, or?
Oh yeah, sure.
All right. Okay. Okay. They are asking, Camila is asking about, which degree of TBI are you including in the audio feedback? Is also mild TBI?
Yeah, it's a mild TBI, but they're chronic. They were like at least 3 months out.
All right. All right.
Yeah, mild TBI.
Okay. And then Pablo Lefort is asking about what is going on with the dual task in mild TBI. I don't know if you have some data.
Yeah, it's people like that's part of the clinical practice guideline to work on dual task, but it's in all of our studies, it's not as obvious at all as like Parkinson's. It's like really clear. TBI, it's not clear. They do recommend it, but from what we've found, it's not it hasn't really, we haven't, maybe we're doing the wrong dual task, but we haven't found like really clear differences on like it's like very mixed. So I think the jury's still out a little bit on how helpful dual task is, even though we do it in therapy and it's recommended, but it's not as obvious, I think, as like stroke or Parkinson's. Yeah, or elderly. Because also like most of the people we see are youngish. Because we're funded by the military, so they always want our ages to be similar to military ages, which is like 18 to 50. So that might explain like why we don't see that much with dual task cost in our younger groups of people. Yeah.
Okay. My colleague from George Fox is asking, Ruth Holloran is asking, in your motor activation group, were intervention better tolerated as compared to vestibular ocular for patient with dizziness or nausea?
Oh, yeah, that's a good question. I don't know, because this is like just starting, so we actually haven't started this yet. But that's a good thing. We should definitely keep track of that, because yeah, sometimes with our people, they can't tolerate a lot of the vestibular stuff. They get nausea, and maybe they can tolerate this better. I'm not sure.
All right. And the last question is if you think this principle in adults are, I don't know, can we translate to pediatric population with TBI?
With mild TBI?
Yeah.
I would. Yeah.
Right. Sorry, I couldn't listen the last part because the internet
I
doesn't
know.
work.
My internet. I keep getting a message that my internet's unstable. Can you hear me?
Yes. Yes.
Okay. Yeah, I was saying there have been no studies on pediatrics yet with
All
this
right.
kind of measure, but I would assume it would be the same thing.
Okay, and now I promise is the last question from Mireia. She is asking if you have to prioritize one intervention for the delay, motor delay, which intervention did you or will you choose?
I think if I could say two, it's going to be like perturbations, like rapid translation so they can step quickly, and then also using that audio feedback. Because we already saw that did help it in the previous study. Yeah.
Awesome. Thank you, Laurie, for all your experience, knowledge, and
Sure. Thanks for having me.
dedication for this talk.
And, yeah, it
And
was
thank you,
great.
everyone.
All right. Thanks, everyone.
All right.
Okay.
Bye-bye.
Bye. Bye-bye.